So evaluating the lumbar spine, we're going to be feeling for the transverse process to see whether it's tender and whether it's posterior, okay? If it's tender and posterior, that's in dysfunction, and so we'll want to deal with it, okay? You're going to use the leg to bend it up so that we can decide, is it flexed or is it extended? We also will be using a twisting motion on the leg to decide whether it's side bent to that same side or whether it's side bent to the opposite side. So in other words, whether it's a type 1 or a type 2 type of problem. So demonstrating it on the patient, we're going to put our hand underneath to the level of the transverse process, start with L5, and put a direct pressure upward, okay? As you put that pressure upward, if there's any tenderness and it's posterior, you're going to have a tissue texture change there so that you can recognize it. If there's nothing there, you move up to L4, another inch up, L3. We got a little bit of an eyelid lift there, so we know we've got a little bit of a problem, and there is some texture change there, and this is a little posterior compared to the rest of them. So now I'm going to take and bend the leg up, and we need to bring the leg up to the level of that vertebra, okay? And then we will test it to see, does it like to go in? Does that tissue get softer that way? Or if we bring it out, does the tissue get softer that way? Okay, whichever way it gets softer, if it gets softer going in, it's flexed. If it gets soft going out, it's extended, okay? So once we've made that determination, then we're going to see, is it side bent to the same side, being a type 2, or is it side bent to the opposite side? So if we take and move the lower leg outward, okay, that will tend to side bend it towards, in this instance, the left side, and see if it gets softer, or we'll rotate it towards the right side and see if it gets softer. In this case, it gets softer going to the left. Okay, so she's left side bent and she's left rotated. Okay, and she's flexed. Okay, so this is softest. Now she's softer, and we've got it just at that level. So once all of that is as soft as possible, that's when we put in our compressive force right to our finger, and then we're going to bring it in an arc around, out, and back down onto the table, okay? Generally speaking, you're gonna actually feel a little shift there as it makes its change, okay? Under your finger, it should be soft, and the tenderness should have gone away. Okay, once you've tested one side, now you're obviously going to want to test the other side. So you'll come in and again check starting at L5, move up, and see what if you have another one that's not heavy, okay? You'll have the patient bend their leg up to that level. Again, you'll see, does it like to go in or does it like to go out? And luckily for our videos today, it likes to go out, so it's extended, okay? Again, we're going to check and see, is it a type 2? So we'll bring the side bending component into it, and then we'll take it to the opposite side, okay? So it kind of likes this. So in this case, we've moved out a little bit, the tissue's soft. Now we're going to apply our compressive force, and we're going to go up, inward, and down. And again, retest it by poking back up. It should be much more compliant, and the tenderness virtually should be gone. Notice that the pelvis, the axis is not straight, but rather it's angled. Therefore, when you have a anterior rotation, it's going, the innominate, instead of just going straight down, actually goes out towards the side. And in a posterior rotation, it's going to come back in towards the midline. Yes, with a still technique, slide down, let me see. There you go, okay? If we have an anterior rotation on this right side, meaning that the ASIS is low, PSIS is high on that side, we're going to put our finger on and monitor the lower pole, which is at S3, okay? And to bring it up, and the leg is going to come towards the outside, again, because it's rotated outward, okay? You're going to bring the leg up just to where you feel it at your finger in the back, Okay, your compressive force goes directly to the finger, and then you'll rotate up, over, maintaining some internal rotation as you bring it on down in its direct technique. Then you will reevaluate. Simple as that. For a posteriorly rotated innominate, okay, again, that's more of an internal, and so we're going to be monitoring at the PSIS, okay, or the upper pole, okay. You'll be bringing the leg up, and because it's more internal, the leg will be a little more internal to start with, okay. Again, now your compressive force goes to that finger. You'll come up, outward, and down. Okay, for the innominate shears, again, we call that this is not a straight up and down joint, but it has an angle to it. So if it's an inferior shear, this is going to come basically a side bending inward, and if it's a superior shear, it's going to go outward. Okay. So that tells you your position of ease, and hopefully will make sense as we demonstrate it. Okay. So if we have a superior innominate shear on this left side, because of that angle outwards that makes it more relaxed, we're going to be taking the leg outward, basically 15 to 20 degrees, again, to be in the plane of that innominate connection with the sacrum. We will internally rotate the leg just slightly because that will lock the femoral head into the acetabulum. Then we can apply a traction downward and essentially walk it across the midline, which then will bring it into balance. Recheck. Again, you can recheck with the medial malleoli and recheck with the innominates, anterior ASIS and PSIS. For a down shear, okay, again, that is angles inward, so we want to take the leg up across the midline, and because it's down, we're going to be pushing it up, so we will apply a compressive force into that joint, and then simply walk it back out to the outside, relax our tension, bring it back. Again, can recheck. ASIS and PSIS. Remember that once you've dealt with the dysfunctions of the lumbar area and the pelvic area, the sacrum only has 4 potential diagnoses in the still technique. So the first thing you'll do is find the PSIS. However, that's not what we use for the diagnosis. We're going to use the sacral sulcus with our fingers. So your fingers should be level in the sacral sulcus, and then ask your patient to bend forward with the elbows between the knees. Watch for the finger that goes up, which is on his right side. Come back up, please. Okay. And then the next is to feel the ILA. So you come in and move up. The one that you feel first, which means it's the closest to the table, is the significant one. And in this situation, it is also on the right, which means he has a unilateral right sacrum. And we name it for the seated flexion test where the finger moves highest. For treating this, we're going to monitor at that level, and we will rotate the body towards that side until we feel the relaxation. Once we get that, we'll apply our compressive force to our fingers, maintain that compressive force as we rotate away. Back and retest. And the fingers go up the same, meaning we have had success. Diagnose the sacrum. We're going to first find the top of the iliac crest, follow down until you find the PSIS, put the fingers in the sulcus, and make sure your fingers are level to start, and then ask your patient to bend forward with the elbows between the knees. You watch the fingers. This on the side, the left one goes high. Come on, back up. And then we're going to check the ILA. Basically approximately 1 inch on each side of midline. You're going to come up until you feel the edge of the ILA. And here we're looking for the side that is the closest to the table. And in this situation, it's on the right side. So what we now have is we have a left diagonal sacrum, because you name it from what your seated flexion test showed you at the base. So to deal with this, we'll monitor at the dysfunctional left side. We will side bend them toward that until we get release sensation, and then we'll rotate them away until we have full softening. We'll apply a compressive force directly to that sacral base, and then we will reverse. So we'll then side bend them away and rotate them toward in a nice, smooth, slow arc. Bring them back to neutral and retest. And those fingers come up level. So again, success.